Yes.
It's crazy.
Yeah.
Anyways, all right, so getting to our show, majority of us are unaware of the importance of breast health. We shy away from asking questions or concerns related to our breasts. Dr. Fernando Angarita joins us this morning to educate and answer questions related to breast health. Dr. Angarita is with the Division of Surgical Oncology at Houston Methodist. His clinical focus includes both breast cancer and benign breast disease. Dr. Angarita's research interest is in geriatric oncology. Welcome, Dr. Angarita, to Chai Time.
Good morning. Thanks for having me.
So good to have you here. So how are you doing this morning?
I'm good. Excited to be here.
Yeah.
So
Yeah.
happy to talk with your guests and,
Yes. Yes, get more into, educate us on breast cancer and breast-related illnesses and things like that, because I think we always talk, when we talk about our health, it's never, about our breast, right? We feel very shy, and we just kind of like ignore it, I guess, I would say.
Yeah.
So this is nice that we are able to talk about it, and for you to share your knowledge with us as well. So my first question for you would be, what are common signs and symptoms for breast cancer?
So generally for breast cancer, we hope that patients come in with no symptoms. We want patients to be able to come in with their cancer being picked up on a mammogram. The whole purpose of those types of tests are to detect when the cancer or the abnormal cells are very early on. And so hopefully patients come in that sense with no symptoms. Okay. It doesn't mean necessarily that if someone comes in with symptoms, say a mass or skin changes or some abnormality in the nipple, that it's advanced disease. It just means that, things have grown a little bit and now they're actually noticing it, or a physician, a nurse, or somebody that that has seen them recently has noticed some subtle change. So certainly a mass is probably the most common thing that someone will say, oh, this is breast cancer. But not all breast cancers develop like a mass.
Okay.
Sometimes it's very subtle and you can only pick it up on a mammogram. There's other things, like I mentioned, skin changes. So particularly around the nipple, there could be some flaking, some ulceration, and also the nipple can be distorted. So if it's sort of everted or inverted or moving to one side or the other, any of those things can be certainly something different and should be looked into.
Okay. And I know when we go and do our physical, the doctor sometimes asks us, do you do your self-examination? So how important is that? Because most of the time we are like, no, we have this look like, and sometimes we don't even know how to do it, right? So how important is that?
Exactly. So, earlier on when screening was being, looked into and developing and sort of establishing that the use of mammography, self-exam was a component. Now, more recently, and I would say probably in the last 5-10 years, that has changed. And so we really generally don't, recommend that every woman do a self-exam on a daily basis, weekly basis, monthly basis. What we do recommend is what's called self-awareness, and just being more in tune with, are there any subtle changes or anything that's different in their breasts?
Yeah. Yeah.
All right.
I think we'll change it.
That could be, that could prompt them to go see their doctor. Again, the whole purpose of screening is to pick up these subtleties, these subtle changes quite early on.
Okay.
But mammograms are only generally done every year, and I think, we'll talk a little bit about screening in a bit, but in between, if there's some type of change, then that could be a reason to visit their doctor, their PCP, and have that looked into. But at least every woman should be self-aware of any change in the contour of the breast, how the nipple is lying, skin changes around the nipple, any abnormal growth or change in the breast.
Okay. And so what is the difference between benign and malignant tumors?
So when we say malignant tumors, we think of that as cancer.
Okay.
So that just means an abnormal growth that can either grow within the breast and stay in the breast, and that's what we consider a precancerous type of cancer which is typically what's called a ductal carcinoma in situ, or DCIS. That's a stage 0 breast cancer. That's as early as it's going to get. And that all needs treatment. And there's different types of treatments that have to be personalized depending on the patient and the tumor factors and so forth. The other type of malignant breast cancer is the invasive type. And that's the type that can grow within the breast, but can also spread to the lymph nodes and to other areas. And that's what people technically or typically call breast cancer. That's the one that, may or may not need chemotherapy and may certainly need surgery and other types of treatments. And that's really the big focus of screening, is to detect that. And the majority of breast cancers are in fact invasive. It's about 80 to 90% of all cancers that are detected on a yearly basis are invasive.
Okay.
And altogether, that's what we consider malignant breast cancer. The benign breast growths, or benign disease, can present like a growth. It can be a lump, it can be a mass, and so definitely there's something that's growing there. But those cells are not atypical. Those cells are not going to invade into the breast. Those cells or those lesions won't go to the lymph nodes or other organs. They may cause problems, distortion in the breast, pain, discomfort, and so forth. In that we also include abnormal nipple discharge, and very subtle things such as benign calcifications on a mammogram. So that's a big umbrella term that encompasses a lot of different types of diseases. But fortunately, it's nothing that would pose a risk to a patient's life.
Okay. So should it be still surgically removed, or if there is a lump, and do the doctors usually do that? They just remove it?
It depends. So I think, anytime we get a patient that has a lump or a lesion, a growth in the breast, we have to do a physical and talk with the patient and understand how long this has been ongoing for. Say, for example, a patient who's had this lesion since she's 15 and she's coming in now in her 30s. It's the same lesion. It hasn't grown. It's always been there. It kind of grows up a little bit during her period. It grows down and then kind of shrinks down again. That probably isn't a breast cancer.
Okay.
It's likely a benign disease, such as a fibroadenoma. Certainly there's other subtleties and other types of diseases that could mimic it. And so we would want to work that up, examine the patient, get some imaging, do a biopsy, and then have a discussion with the patient to see whether or not that type of lesion should be removed, if they want it removed. But those would be the ones that we're thinking of, this is perfectly benign, we've worked up the patient, and she's comfortable with that being observed for some time. If there are some subtle things in the lesion or on the biopsy, let's say atypical cells, or it's growing really quickly, or she has a big family history of breast cancer, then we would be swayed to have a conversation about excising it and completing that, or basically removing that lesion.
Okay. So, doctor, when it comes to doing the mammogram, you mentioned earlier that you go once a year, right? But if are patients at higher risk when they have, when the family has had cancer? So should they go more often to get the mammogram done or screening done?
So that's a great question. I mean, generally when we say getting your mammogram once a year, we're talking about the average woman. And when we say average, it's the 1 in 8 risk of 1 in 8 women getting breast cancer. So that's about a 15% risk in your lifetime to develop a breast cancer. That's a woman that has never had breast cancer in her own life. She doesn't have any siblings or relatives with breast cancer. That's the majority of women with breast cancer. You then have what you were mentioning, which is the high risk. Mm-hmm. Those are patients who have, when we look at different factors, how many kids they've had, and do they have a family history of breast cancer, or did they have breast cancer, decades before, they can be categorized as being high risk. And so those patients have screening that's different than the average risk woman. And so in them, we still recommend the yearly mammogram, but you can also add clinical encounters with your PCP or a breast specialist, so that you're being seen at least every 6 months, and then certainly consider something like a breast MRI, which we don't generally recommend in all women. Some women may need it to complement their screening, but in high-risk women, we are generally recommending that they get a breast MRI in addition to their mammogram. There's other things that they should do, and so things like managing their weight and balance diet. And I'd also say that we can also talk about chemoprevention, which is giving a type of medication that can further reduce the risk of breast cancer.
Oh, really?
And those types of things, I mean, are very personalized with the patient, because like any medication, there are side effects.
Correct.
And so that's something that, every patient has to decide on their own with their physician whether or not they want to embark on that.
Okay, so what would your advice be on diet and lifestyle for women who are at higher risk or who are not even at higher risk, just to prevent, breast cancer?
So, I would say that diet is one component of reducing your risk of breast cancer. The main thing that's going to reduce the risk of having advanced breast cancer and having a treatable breast cancer is getting a mammogram. So completing that and doing that and seeing a physician. It's not just getting the mammogram, but also seeing your physician and having a breast exam and having that conversation so that your physician can pick up on risk factors that may, for example, put you in that higher risk category, or sway them to recommend having you undergo a biopsy or something else to complement your screening, depending on what's being found. So the diet component is not something that would absolve the other things, but I think complement and further help reduce your risk of breast cancer. So things like maintaining, a healthy, balanced diet, minimizing alcohol intake and sugar intake. And it's not that, consuming sugar is going to develop breast cancer. If you have a breast cancer, it's going to make it grow quicker, because all cells, normal and cancer cells, need sugar to grow. But what we know is that obesity is really the driving factor to increase breast cancer, especially in postmenopausal women. And patients who've had breast cancer, we want them to maintain at least their weight, or get into that normal weight range, so that they can prevent getting breast cancer in the future, because it's the increased fat in their body that can help produce estrogen. And those are one of the things that helps cancer cells divide and grow.
Right. So my next question also would be the oral contraceptives, because we know that sometimes they say there is the chance, a higher risk of getting breast cancer when you're on oral contraceptives. So is that true then?
So it's prolonged use with oral contraceptives, but fortunately, once they are suspended, and at least you're off of it for 10 years, your risk is back to the average woman's risk. And again, I think that the key thing that I hope women understand is that one risk factor isn't going to cause the breast cancer. There's a lot of different little things that in your life and in your personal medical history and your family's history that are going to either increase your risk or decrease your risk. But oral contraceptives is one of those things that is important, and it's a decision that each patient should have, and that allows them to whether it's being taken for symptoms or for birth control purposes, there is that added risk. But there's other things that they can do to mitigate that risk, and then once they're off of it for a certain period of time, that risk is resolved or eliminated.
Okay, well, that's good to know, because I know that sometimes a lot of us are, skeptical about it, and especially when it comes to medications. Of course, we know there are side effects, but we do not want to create, create that extra problem for us, right? So that's good to know that what you just said about the oral contraceptives. Yeah.
And the other thing I would add is, like I was mentioning, there's other risk factors. So really that one thing that drives risk in patients, other than having had a breast cancer themselves or having a big family history of breast cancers, is having a prolonged period of time in their lifetime of exposure to estrogen. So women who have had their period quite early on, their first period, so anyone who's under the age of 11 who's had their period, that's a risk factor. Okay. That can't be modified, unfortunately. There's no control in that. Having menopause after the age of 55 is another risk factor. So that if a woman started their periods really early on and finished their periods or went into menopause quite late, they're going to have a long time span of being exposed to estrogen. And so those are things to be mindful of. And Correct. So that is something to factor in when seeing your doctors and looking into breast health and breast awareness.
Okay. And so you did mention about sugar, because that is the other thing that a lot of us, I mean, we love sugar, but then also we have to be mindful of how much the intake and everything. I've also heard that about the antiperspirant,
Yes.
that they say that you should not apply, antiperspirant because that could cause breast cancer as well. So what are your thoughts on that?
So that's a myth that's been going on for quite some time. I mean, there are some studies, some research that's been done looking into it. Not the best studies, but nonetheless, there isn't any conclusive evidence to say that antiperspirants and the molecules that are or chemicals that are in that to cause breast cancer. I think it's more of an association, but not really a causality, meaning it doesn't really cause cancer. It's just because women are putting it on and they get breast cancer. There is that thought. But what's interesting, I think, is that the area in the breast, if you kind of divide it into areas, into 4 quadrants, the area that has the most amount of breast tissue is actually closer to the armpit.
Correct.
So, and that's where most women get their breast cancer. Also, some thought is that, if women are shaving their armpits and they then put on the antiperspirant, that can travel into the lymph nodes and cause breast cancer. That, I think, has not been proven, and more so, lymph nodes are very reactive. So any type of infection, any type of scratch or nail infection, for example, the lymph nodes are going to grow and react to that because they're trying to defend you against some type of infection. But fortunately, they kind of go back into their size, but that whole process does not cause breast cancer.
Okay. All right. And also, when it comes to breast cancer, we think that it only happens, when you reach a certain age. So it's for middle-aged women or older women. So is that true?
So for the average woman, the average risk woman, the peak of it is really starting in the 50s, but it keeps going up into the 60s. And actually, the more recent data shows that the average age of diagnosis of breast cancer in the U.S. is around 62 years old. But we are starting to screen patients in their 40s because generally breast cancer is a slow-growing cancer. We want to detect it very early on so that the treatments are more minimal with less side effects. But you're right, breast cancer and any type of cancer, really, the risk goes up with age.
Okay.
And so we do generally see patients in their 70s, 80s, or 90s with breast cancer. Fortunately, breast cancer is different in a woman who's older than someone who's, let's say, in their 40s or 50s. Those breast cancers in the older women are generally slower growing. They have a lot of features in the biology that are very amenable to less toxic treatment. So we generally don't have to give chemotherapy in women who are older. They may certainly be even treated just with surgery. They don't need radiation. We can avoid some of the other type of toxic treatments. Again, all that's personalized to the patient because it's not only about age, but how fit they are and how strong are they to withstand some of these treatments. But I think what is important to note is that as women get older, they shouldn't avoid their mammogram and their follow-ups with their physicians, because if they're past their 60s, it doesn't mean, I'm not going to get a breast cancer, this is something else. You can still get breast cancer. It is still treatable. It is still manageable.
Okay. So if it's surgically removed, and so is there a chance for it to come back, or in different parts of the body, or is it like it's done?
That's a really good question. So the risk is always there. So anytime you are diagnosed with a breast cancer, the risk is there. Even if you have a very aggressive treatment, let's say where both breasts are removed, you can still get breast cancer coming back. What we do as surgeons, and we work in conjunction with medical oncologists and radiation oncologists and all the other cancer specialists, is to tailor the treatment to the patient's tumor and their medical history, so that they can get the best directed therapy to reduce that risk in the future. So we add things like, for example, radiation therapy. So if a small area of breast can be removed with the breast cancer, the radiation therapy, which is done after the surgery, basically sterilizes the tissue to prevent the risk of breast cancer coming back in the breast.
Oh, okay.
There is still risk, for example, that the breast cancer can come or develop in other parts of the body. So you would have to take certain medications, and that could be chemotherapy, not always.
Mm-hmm.
There are some oral medications which are not chemotherapy, such as tamoxifen and anastrozole.
Correct.
And so those are medications that some patients benefit from and reduces the risk of breast cancer coming back elsewhere in the body.
Okay. And so with early stage of breast cancer, does not recur, or if you've detected, you've taken care, there is still a chance of that?
The risk is always there. It's very low. So when we say early stage breast cancer, it's that type of breast cancer that's just in the breast. It hasn't gone to the lymph nodes, it hasn't gone elsewhere. The risk of it coming back in the breast or elsewhere is much lower than if that patient came in with a big breast cancer and multiple lymph nodes that have breast cancer in that. That patient has a higher risk that it's going to come back in the first 5 years.
Okay.
For the early stage breast cancer patients, if they go through all this treatment, that risk is much lower. And so that risk of it coming back is not necessarily within the first couple of years, 5 years. What we see for most of those patients, especially if their tumor is estrogen, progesterone positive, which is the most common type form, thankfully, and is the most receptive to that endocrine therapy, that cancer may come back 10, 15, 20 years. And so that's why women still need to get mammograms and have follow-ups and be aware of their breasts to know that, and still be in line and still be undergoing checkups, because that risk is always there. But it's very low.
Okay.
And even if it does come back, say 10, 15, 20 years down the road, the treatments are still available. There are still things that are available for them to have that treated. It's very manageable. We get a lot of patients that, for example, were treated in their 50s and now they're 85 or 70 with a new breast cancer on the other side, same side. Still very manageable. It's still going to be early stage. They, can get through it if they just go through all these different types of treatments.
Okay. And when we do self-screening or we find a lump, would that definitely be breast cancer? Because, we start panicking, right? And we say, oh my God, we got a lump. So is that true, that if there's a lump, it is breast cancer?
Not necessarily. I do think that if you feel something that's new and abnormal, definitely go to your doctor to have that evaluated, and definitely get some type of mammogram and an ultrasound. It's going to depend on how old you are. So if you're a younger patient, under 35, we should definitely be getting an ultrasound because the breast tissue is quite dense. You might end up getting a mammogram as well, but if you're over 35 or plus, it's going to be a mammogram. So you definitely need a physical, you need workup, and like I mentioned earlier, not everything that grows in the breast is malignant. Not everything is precancerous, not everything is cancerous. There are some benign lesions. And the thing that happens with the breast is that, like the rest of our body, it changes and it ages. So once, at the beginning, or if you're quite young, the breast tissue might be very dense. As you get older and you get close to menopause and after menopause, or if you change medication, say you stop taking oral contraceptives, the density changes, and so it becomes a little fattier. So something that was there maybe in your 20s or 50, in your teens, and you never really knew about it because your tissues were so dense, now may become a little bit more apparent. But to know what it really is and have a name to it and see what type of treatments you might benefit from, or what type of follow-up, you need to be seen by a doctor. You should have that looked into. You should have that image, mammogram, ultrasound, what have you, maybe a biopsy as well.
Okay. So has treatments really changed from the past to current now, or is it still the same, do you feel?
I think breast cancer, and that's one of the reasons I got into this field, is how much it has evolved. If you go back 100 years, every patient with breast cancer, because screening didn't exist, mammograms didn't exist, they had to get the whole breast removed. So it would be these huge disfigurating surgeries where the whole breast was removed, the pectoral muscle would be removed, all the lymph nodes would be removed, and patients would get very dramatic lymphedema, very disfigurating. They didn't get chemotherapy because it didn't exist. So everything was, or the treatment was really relying on surgery.
Sorry, doctor, I have to interrupt you a bit, but we're really getting into this. We just have to go on a short break, but when we return, we'll continue with our conversation. We're going to go on a short break. I'm in conversation with Dr. Angarita. This is Chai Time on 99.5 FM. 99.5 FM, we are in conversation with Dr. Angarita on breast health. And doctor, so we were talking, I was asking you about in previous years as things changed with treating breast cancer, correct?
Right. So as I was mentioning, I mean, every component of breast cancer treatment has changed, has evolved. I was talking about how surgery has gone from these very large disfiguring surgeries with a lot of, post-operative changes that affected women's quality of life. That was 100 years ago. Now, because of screening, we are detecting cancers that are smaller. And we know more about the biology. We know more about the different types of variations. So I said invasive cancer is the type that can spread, but within that there's multitudes of variations, and each patient cancer has to be treated based on what it is. And so again, some patients may not need chemotherapy, and that's based on the tumor biology. There are other types of patients that need endocrine therapy. But if you gave it to somebody who didn't benefit from it, then they shouldn't necessarily be taking it. So we basically evolved from relying on surgery and not knowing anything other than there's a cancer in the breast to knowing so much about the cellular biology, the DNA, the variations, that we can really tailor that treatment, tailor the surgery, tailor the radiation, tailor the chemotherapy, and all the other medications. And it's really evolved. I mean, and it keeps evolving. I mean, the combinations of chemotherapy, drugs, and the order of the medications keeps evolving, and it's one of the fastest growing fields in oncology.
Okay. Well, it's good to know because it does get better. Like when you mentioned earlier before we went on break that, initially they would just take it off, right? Your breast was just taken off and, removed. And it was like, that's it. But now with ongoing research and everything, things are improving, getting better. Like, no, we don't need to take that drastic step because mentally it affects the women a lot. Mentally when you're, it not only physically but mentally too, it is hard.
Exactly, yeah. And so if anything can be personalized and tailored to you, you are getting what you deserve and what is going to benefit you.
Correct.
So, breast cancer is one of those types of tumors, and a lot of, things in oncology have, developed into that. But breast cancer, because of the numbers and how common it is, and the attention it gets and the funding it gets has really become such a very personalized and a field that really evolves quite quickly.
Mm-hmm. Yeah. And so what are dense breasts and how does that factor into diagnosing and treating breast cancer?
So density means how much breast tissue is in the breast. So the breast is composed of two types of tissue. There's the fat, which is what gives it the volume and the shape of the breast, or the actual size of the breast, and then there's the breast tissue, which is responsible for the function of the breast, which is to produce milk. That's where breast cancer develops. It's in that breast tissue. Depending on how much tissue and how compact it is, you may or may not have dense breast. So there's a classification that the radiologists use to grade a woman's breast density when they're looking at the mammogram. And so it can be as non-dense as a fatty breast. So a fatty breast is basically, it's completely replaced by fat. There's breast tissue in there, but it's so scant that it's not causing any visualization problems to the radiologist. And it goes all the way up to extremely dense. And so those are breasts that have a huge amount of breast tissue in that. Most patients who have that are going to be young patients. So it's going to be the patients in their 20s, 30s, or 40s. And that's because that they're in their prime of when, biologically the breast is ready or is meant to be available for breastfeeding. Once menopause kicks in and so forth, that breast tissue is going to change. That the function of the breast is lost. You're not going to be breastfeeding, so the tissue basically changes and is replaced by fat. And fortunately, though, about 35 to 40% of women have dense breasts, so it's not the majority of women. But I think what's important to note is that women should be aware of their density. And in fact, on their mammogram reports, that is required to be reported. And so it gives the patient, I think, it empowers them to know, what type of tissue they have, and allows the radiologist to know whether or not, they need additional tests to supplement that mammogram, whether that's with an ultrasound or an MRI, or if they need to have another mammogram in a shorter interval and not wait necessarily the 12 months. It's just patients, again, it's tailoring that treatment and not treating every woman with a mammogram every year. And let's move on. No, it's okay. This patient is a little bit different. I would maybe recommend getting an MRI just for the sake of understanding and knowing what's in that tissue. And if it's clear, okay, fine. And then, see again in 6 months or 12 months.
So even though your mammogram has come out okay, you would still recommend to go and get an MRI or?
Well, it's going to depend on what that mammogram shows.
Okay.
So not every woman needs an MRI.
Okay.
I think we've become quite lenient with MRIs because, we have so many machines of them everywhere and they're quite easy to get. But over-testing also has its limitations. And so knowing which patients need that MRI is important. Like we said, the high-risk patients definitely need it. Patients who have extremely dense tissue may need an MRI. It gives more information. But like with any test, going through with a test may imply getting another biopsy, getting another set of tests, and there is that possibility of what we call a false positive, something that we think is there. There could be some abnormal cells, but it really isn't. It could just be the tissue is looking funny by the way the breast is being compressed on the mammogram. So it's being mindful and aware of that breast density and that possibility that you may need additional tests. And it's not something to get scared about, although nobody likes getting more tests and it's worrisome. But I think that once you're aware of knowing that you have dense breasts, that extra test should just be considered part of your regular screening. And maybe that can help to some extent mitigate the anxiety around getting a mammogram and getting tested.
Right. I'm glad I asked you that question because when we were on break, this happened to me personally. So when my mammogram test came, I was fine. But then I saw this thing at the bottom saying, you do have a dense breast, so you should be more careful, or like go for more tests or something like that. It didn't say more tests, but I don't quite remember. But for me, I was like, I'm okay. So what does that really mean? And I never took it further. But now after talking to you, I'm like, yeah, I should, go and see my doctor, talk about it and see, if I need to go for further test or something like that. And especially since I do have, my grandma who passed away with breast cancer many, many, many years ago. And it just dawned on me that, I shouldn't take it lightly. I should really probably go and see my doctor for that.
Exactly.
Yeah. Thank you. Is surgery the only option when it comes to breast cancer?
That depends. That's a big question. I think that again it boils down to who the patient is. We have sometimes patients that are frail for medical reasons. And it's not necessarily an older patient. There's a lot of young patients that also have a lot of medical problems, and they may not be fit to undergo surgery. So, working with the medical oncologist, the radiation oncologist, those are the types of patients that we discuss in a tumor board setting, in a group setting, to see what other treatments other than surgery are available. So, for example, in older women, they tend to be estrogen receptor positive, so they're sensitive to hormones. We can maybe just treat it with oral medication. Easy to take, as long as you're taking it, but it's much, it's going to take a less toll physically and maybe psychologically on that patient who may not be safe enough to take to the operating room. But the majority of breast cancer, we are or should have some type of surgical treatment. I don't think we're just there yet to say that it's going to be completely eliminated with medical treatments, chemotherapy or this endocrine therapy or radiation. I think surgery certainly still has a place in the treatment of breast cancer, but it is an evolving target or portion of treatment because as the biology of the tumor is more understood, the medical treatments can be tailored even further, and so hopefully, I guess surgery may end up being a very small component.
Okay.
of the treatment. But currently, once we have a patient, in our clinic and we're seeing them, we do recommend surgery at some part of their treatment. And for some patients, that might mean it's the first treatment, and then they get their additional treatments, the radiation, the chemotherapy. And for some other patients, specifically if it's an advanced cancer, we want to treat them with the chemotherapy to shrink the tumor, make the surgery smaller, make the surgery have to be more extensive, and but it ends up being 4 months or so after their diagnosis, after they've gone through all these other treatments.
Okay. So what is the connection between breast cancer and genetics?
So genetics, not every breast cancer has a genetic history, meaning not every patient has a genetic mutation causing their breast cancer. Certainly there's some changes in the tumor biology in that patient, but it's relating to that exposure to estrogen or previous history of breast cancer in themselves. About 15% of breast cancer is genetic, meaning there's a hereditary component. These are patients that have a big family history. Mother, aunts, sisters, all the aunts, all the sisters have breast cancer. And those are patients or families that have mutations of certain genes. The more common ones are the BRCA gene, the BRCA1 and 2. Those were the first ones that were discovered, but as genetics has evolved and it's become more available and there's more research and funding, we have developed and understood more genes related to breast cancer. PALB2, P10, CHEK2, and so now that patients are getting tested, we know that they also play a big role. And so it's in those patients that there is a big genetic component, and so their treatment, in addition to managing their breast cancer, it's having that discussion of, well, how do you prevent that breast cancer on the other breast or the same breast in the future? Those are the types of patients, that we have a really in-depth conversation about prophylactic mastectomy, basically removing all the breast tissue to hopefully reduce as much as possible their breast cancer risk, talking about oophorectomy, removing both ovaries to further reduce that exposure to estrogen in their lifetime.
Okay. And so do you find, doctor, that now, whenever we do go for our examination and all, breast cancer is more, is a question that is more prevalent now than before? We do focus more on that as well.
Should the genetic component?
Yeah.
We take a thorough family history to sort of pinpoint, the risk of the patient. The majority of patients, interestingly enough, don't have a family history of breast cancer. They're usually the first patient that we see, unless we have a family or a known group of family members. But most patients that come into our office don't have a family history, and so that's what's shocking to them. That I'm the first one. How could this be? And so, but still knowing that there is that component of family history is very, very important for themselves, for their other family members, for their children. Sometimes that patient could be that first patient of a mutation, and so we are now more frequently testing all breast cancer patients with breast cancer to see whether or not they have any type of mutation that could maybe explain that. It won't change their treatment most of the times. Very few things get altered in their medical treatment, but it may help them decide whether or not they want to do something about the other breast, or if they're going to undergo more intense screening, that high risk type of screening, if they want to do any further risk reduction with regards to ovarian cancer, which is sometimes linked to those genes that cause breast cancer. And then also, once you have a mutation, there are other types of cancers that can develop: colon cancer, pancreas, prostate cancer, melanoma. And so it's understanding that that mutation can, it opens basically a floodgate to other testing that may be necessary. Okay.
So almost the whole hour we are talking about women, breast cancer. So my question to you would be, do men also get breast cancer?
Yes. So breast cancer, it's a woman's disease because that's who mostly gets it, like you said. But about 1% of all breast cancers develop in men. So men should not be forgotten. We do get, we do see several patients with breast cancer a year. And there's a lot of differences, obviously in the presentation because, Men don't think that they have breast, but we do have breast tissue. It's more compact, it's smaller, it's all, basically behind the nipple. And that's really where the breast cancer develops. It doesn't involve the whole chest. But because it's such a small area, the surgery treatments are quite limited. For a woman, sometimes we can do a lumpectomy where we remove just a portion of the breast. But in men, because it's a smaller area and it's involving, unfortunately, the nipple and the middle part of it, mastectomy is generally what we are recommending. The other types of treatments are basically similar, but hopefully over time there's going to be more research focus on male breast cancer patients, because a lot of the data that we apply to men with breast cancer is coming from studies that were primarily or exclusively done in women.
Okay.
Hopefully through collaborations with different centers and to just recruit more patients, we'll be able to get more patients recruited for different studies to know whether or not certain treatments can be avoided or altered, the organization, the timeline and so forth.
So is screening the same way also for men?
So for men, we don't recommend screening. We basically recommend it for male breast patients or males with a significant family history of breast cancer. Say if we know that they have a genetic mutation in them. So if they have a BRCA1 gene mutation, maybe that patient may benefit from a mammogram or an MRI. But most of the times and most of the guidelines do not recommend for men to get mammograms on a yearly basis.
Okay.
For the average risk male, like no family history, no previous history in their family, it's more about breast awareness. And if there is any change in the nipple, ulceration, a little lump in the back of the nipple, or pain around the nipple, that may be a mass and that should be looked at. They should definitely get a mammogram and ultrasound, see their doctor.
Okay, so for men, if they go for their physical, they should, as women, we ask about our breasts, like some of us. So would that be the same for men when they go for their physical too? Would that be part of?
So I think if they have a symptom, it's important for them to bring it up and tell the physician, hey, I'm feeling a lump behind my nipple, or my nipple feels a little bit too sore. Men can get what's called gynecomastia, which is that abnormal growth of the breast tissue behind the nipple, but it's not breast cancer. They can get it, commonly in their teenage years. They can get it if they have liver disease or they're taking some medications, for example, for hair growth, or if they do marijuana. There's certain drugs that increase that growth of the breast. It can cause tenderness, it can cause discomfort, but it's not a breast mass. But it's still important to have that awareness and have that looked into with a mammogram or ultrasound, maybe a biopsy. But if they're not having any of that and they feel something abnormal in their breast or their nipple, I would definitely recommend that they mention that to or seek help, medical attention, so that it can be looked into. Because again, the earlier it's detected, the better it can be treated, the quicker it can be treated, and the treatments may be less toxic and so forth.
Okay, so and there's more research being done also where it's related to men having breast cancer.
Yes, I mean it's a challenging area because it's so sparse. You'll see a couple of male breast cancer patients a year in one center, and so you can't really develop a clinical trial like that because just the numbers wouldn't be possible. So it's a lot through collaboration. But that's the goal, because unfortunately men are overlooked in breast cancer because the studies exclude them from all these big randomized trials that are what we built our recommendations and guidelines and management for all the other stuff in women.
Yeah, but it's good to know. It's good we are talking about that because it is always that misconception that it's not men don't get it, and it's only
because there was a question on Facebook, how do men get breast cancer? But I think you answered that through genetics, right?
So I think that's the first thing to know, that we as men, we have breast tissue. Just because we don't have the shape and the volume of a breast, like a woman, there is breast tissue there. It's just biologically, by our development, it doesn't develop into the amount or size that a woman gets, and so that's why in a man, it doesn't flourish to the whole breast. It's just clumped behind the nipple.
Okay.
So, but and men have 1/100th of the amount of breast tissue that a woman has. So even there, that's even further diminishes the risk of breast cancer, but it's not a 0% chance.
Yeah. That's good. So, Doctor, any advice for our listeners before we wrap up? Any tips and advice how we have to just, kind of like...
I think having these types of conversations are important. I think,
Yes.
I think, what you mentioned earlier on is important. Sort of the stigma around breast health is important to eliminate that. I mean, this is a prevalent disease. It's a manageable disease. That's what I tell my patients all the time. Most of the times, for the majority of these patients, we can treat this. We have information for you. We have options for you, and this has evolved. I mean, I think it's important to stick to the mammograms, to the physical exams, being aware of any subtle changes, and seeking out attention, because something as small as a small cancer in the breast can be managed with small surgery. The whole breast doesn't have to be removed, etc. And so it can be very personalized. Left untreated for months to years, and we unfortunately do see those patients, the options get more narrowed, and things end up being more. It ends up being more of a challenging conversation. So hopefully, with these types of conversations, patients can be just more open to going ahead with their testing and not be afraid. I mean, I know no one likes getting tested. Everyone's afraid of everything, but I think it's important to just do that, because it's so manageable, it's so treatable.
Great. Thank you so much for joining us this morning.
Because I think you, like, with your conversation, it made less scary, because as women, like, we've never had a conversation about it, like, especially for me and you, because you learned something new as well.
Yes.
And to know that it's not like, because you hear the C word and that's it, right? Because everything just starts, like, flashing in front of your eyes. But it's not that. Like you said, it is manageable if it's detected early. So, like, talk about it more with your PCP and whatever you need to do. So,
yeah. And even to our daughters, our girls, like, to...
You talk about it, it's taking away that stigma of that, and hopefully, next generations and further down, it evolves, right?
Yes.
You get patients that are shy about getting examined by healthcare professionals. They don't want to go to get their mammograms because they don't want to be, they don't want to inconvenience anyone. But if they go ahead with it, it's manageable, it's treatable. Like it's a big headache and all the things that go around with it. It's a scary time.
Right.
But once you go through that, I see patients that are decades out from their treatment, and as if that was a big disaster, challenging time in my lifetime. But they are able to put that behind them and move forward.
Okay.
Yeah, and even if a family member or friend going through, we ourselves have a better understanding of what it is, and we can support them better. Because if they are afraid and we are afraid, there's no help. So I think this conversation with you has really kind of broadened our minds, and to say that it's nothing to be scared of. Yes, there are so many uncertainties in life, but this one thing, the questions to ask or information to get.
This is the thing about breast cancer is we know a lot. We don't know everything, but we know a lot, and so we can tailor that treatment to that patient's needs, interests, desires, and get them through this. And there's a big group of people. It's not just the surgeon. Like we work with a huge team of people that help patients through different steps along the way.
Correct. Yes, and we also want to let people know, women who are who are hesitant about doing mammograms. It's not that bad. Like we hear stories. There are horror stories that they say, "Oh my God, it's so painful," and it's but actually, there's a discomfort, but you need to get it done.
I think that going to a place that does it regularly is mindful of the patient. I have patients that know the technician that does it really well, and they make sure that when they're going in that technician is there. So there's things around that, and that is also evolving. We're doing imaging or mammogram that is requiring less compression. And so hopefully with time and as technology develops, you maybe not necessarily need to have complete or very significant compression of the breast to get it all looked into. But I think those are, again, mammograms are key.
Thank you. That's true. Thank you, Doctor, again, for taking the time and coming here. And We are fellow Torontonians. I love that. Thank you, listeners, for tuning in this morning to Chai Time. We shall see you again, same time, same place. Y'all have a wonderful day. This is Chai Time on 99.5 FM.